Good morning, everyone, and thank you for joining us this morning for this session on the management of breast masses in pediatric and adolescent patients. This session is brought to you by a collaboration between the Outcomes and Cancer Committees, who both felt that this topic was an important one to discuss today, given the variability in the way we as pediatric surgeons take care of these patients. For one, there is a sparsity of literature on this topic, but mainly there is a large discrepancy between adults and even young adults and adolescents in the way these masses are classified, affecting the treatment recommendations that we often see in the office. So we put together 3 cases today that we hope will demonstrate the challenges that may come up when treating these patients. Each case will contain polling questions that we are hoping for some audience participation. You will find these questions on the HOVA app if you go into the agenda, open this session, and you will see a place for our 5 session polls. We would love for this session to be interactive, so we ask for your participation so we can get a sense of the way we are all managing these patients. And we'll start with our first case.
Good morning, everyone. I'm Sarah Mansfield. I am from Nationwide. I have the pleasure of being on the Outcomes Committee as well as the Cancer Committee, so I'm going to highlight a case that I think will be exemplary of some challenges that come up. So this is a real patient. This is a 13-year-old female who came to my clinic with a palpable breast mass. She felt like she noted it about 2 months ago, but did seem to be growing pretty quickly. Over the course of that 2 months, it went from smaller than a golf ball to a baseball. She had no other symptoms, nipple discharge, skin changes, and her family history was non-contributory. She's otherwise healthy, and her exam was consistent with a firm but mobile mass in the breast, but no other concerning features. So since she came to me, I sent her to our pediatric radiologist for an ultrasound, and found a 5.5 by 5 centimeter lesion, somewhat heterogeneous, with some internal flow noted, but couldn't exactly tell the histology. So for our first poll, I wanted to see what everyone would do with this lesion. All right, pretty good number of people responding, so that's great. So about 60% would excise, and then there's about 20% who would do a core needle biopsy, and also a good number who would observe with a repeat ultrasound in 3 months. So we flip back to the other. So one of the things we wanted to highlight was a recent manuscript that we put together through the Cancer Committee. It came out in JPS last year, and is basically an expert consensus guideline on the management of pediatric breast masses. I don't expect you to, be able to read every single thing in this box, but more to give you a place to go for this reference. Basically, a kid who comes in without any concerning features, so doesn't have BRCA in the family, doesn't have a prior personal history of malignancy. Ultrasound is the imaging of choice by far. A solid lesion on ultrasound, as long as there's no concerning features, like we said, a lot of times on ultrasound, some kids can get non-typical breast, or cancers in their breast, such as rhabdomyosarcoma or lymphoma. Those are usually discernible on the ultrasound. For those that have typical features of fibroadenoma, if they're under 5 centimeters, you can certainly recommend observation, which is important for the developing breast. If they are demonstrating rapid growth on serial ultrasounds, that would be an indication to go ahead and excise them. Or for lesions that are clearly above 5 centimeters and especially 10 centimeters, moving forward with surgical excision is the preferred route. Core biopsy in this age group with a high predominance of fibroadenoma is still pretty challenging to differentiate between fibroadenoma and a phylloides tumor, for example. So moving on with this case, we did do an excisional biopsy, and our pathology came back as a borderline phylloides tumor. Her margins were microscopically negative, but quite close, so 0.2 centimeters from the margin. What would you guys do now? Okay, so 2/3 follow in clinic with regular ultrasound. About a third would re-excise to obtain 1 centimeter margins, and the one person would send for a mastectomy. Okay, we go back to the. So again, there's a lot of details in the manuscript that we put out through the Cancer Committee. Probably don't need to memorize everything, but it's just a good resource to know where to find some of these recommendations, because how often are you going to have that exact scenario come up in your practice? But you actually don't need to re-excise for negative margins in a borderline phylloides tumor. You may even be able to observe the malignant tumors that you didn't do a wide excision at the index operation. We also highlight some of the NCCN guidelines about the recommendations for serial surveillance after excision. So for a phylloides tumor, you do want to follow those patients for about 3 years with serial ultrasounds to ensure that they don't have a recurrence. So again, I just wanted to highlight a good reference for some of these recommendations from the Cancer Committee, and then we'll go on to our next case with Martha.
So here we have our second case, and presenting to us is a 15-year-old female that presents with a right-sided palpable breast mass. She notes that it's been there for about 6 months and there's been no changes in size. She has no family or personal risk factors for malignancy. Upon examination, the mass is small, well-circumcised, and mobile. In addition, there's no lymphadenopathy or skin dimpling present. The primary care provider obtained an ultrasound, and it showed a well-defined hypoechoic mass with smooth borders. It was about 2.3 by 1.5 by 1.3 centimeters, and it also had a posterior acoustic enhancement. So all of these characteristics are aligning with a fibroadenoma. This brings us to our next poll question. So the question asks, a family would like to avoid intervention. Would you repeat the ultrasound in 3 months, 6 months, 1 year, or never? I'll give it about 20 seconds to get your responses in. So it looks like a majority of us think that you would repeat the ultrasound in about 3 months, and the rest of the audience thinks in about 6 months. So now we'll move on to our next poll question. Now, the mass has demonstrated interval growth on repeat ultrasound from 2.3 centimeters to 3.5. Would you perform a core needle biopsy, fine needle aspiration, surgical excision, or continued surveillance? I'll give it about 15 seconds again. The results are still fluctuating a bit, but it looks like a majority of us in the room would perform surgical excision. So now I'm going to pass it on to Dr. Gonzalez to continue.
Okay, in order to better inform how we manage these adolescent pediatric breast masses, the Outcomes and Evidence-Based Practice Committee performed a systematic review encompassing the following questions. What are the characteristics of breast masses that prompt intervention? How should we surveil them if we do decide to observe? And what is the prognostic value of BI-RADS in adolescent breast masses? This is just an example of where we started. We had over 9,600 studies returned in our search. About 7,600 of them were screened, and out of 453 retrieved, only 11 met our inclusion criteria. We had a total of 10 retrospective reviews and 1 case series. Our level of evidence was 4. 11 of these studies addressed question 1, which was addressing what are the characteristics that should prompt intervention. No studies provided guidance on how to surveil these patients, and 3 studies addressed question 3, looking at the appropriateness of BI-RADS in this patient population. We had a total of 819 patients. When the paper specified, the patients were female, and the average age was about 16 years old. Just over 50 patients had a core needle biopsy or a fine needle aspiration. 143 had a surgical biopsy, either incisional or excisional. 228 were reported to have observation, but they didn't provide any details on how often they were surveilled with exam and or ultrasound. The indications for intervention were very limited and not provided in detail, but they aligned with what we've heard from the Cancer Committee, that if the mass is enlarging or already large on their first ultrasound, then that's a good indication that we need to intervene. And most of the patients had an ultrasound if they had imaging at all. None of the patients had mammography or MRI. Although we limited our study to 13 to 18 patients in an attempt to specifically address the question of adolescents, this did lead to some exclusion of papers that we did think were valuable to the group as a whole. So we selected a few key papers to go over that we thought would provide some guidance. And one of these was from Dr. Sanders, and their paper was entitled Clinical Breast Concerns in Low-Risk Pediatric Patients. This is a retrospective review with over 1,000 patients. They were aged 11 to 18, so they fell just outside of our range. 130 of their patients had 160 core biopsies. 99% of them were benign, and the only malignancy identified was actually lymphoma. 203 patients had 266 surgical excisions, and almost 90% were fibroadenoma. They concluded that we should be imaging all palpable breast masses and then proceed if they appear suspicious. If they're less than 3 centimeters, they recommended getting a repeat ultrasound in actually 6 to 12 months, so that's slightly longer than our poll where most people said they would do 3 months. And then if it reaches 3 to 5 centimeters or double, then they proceed with intervention. And if they're over 5 centimeters, that we proceed with excision. The 3 to 5 range is where it gets a little bit gray, but most people would consider doing an intervention to make sure that it's not phylloides. When they looked at these guidelines and then applied them retrospectively to the group, they found that they would have avoided a lot of unnecessary procedures in this patient population. And as you've already heard reference to, it's not something we should take lightly in a developing breast. So next, we're going to talk a little bit more about BI-RADS.
All right, so moving on to case 3. We have a 13-year-old female who's referred with a 3.5 centimeter breast mass, which has been stable for months. She does have a family history of a paternal grandmother that had breast cancer at age 78. On exam, the mass is firm, mobile, smooth, and she has no lymphadenopathy. Ultrasound was performed before consultation, and that demonstrated a BI-RADS 4B lesion. So this is another poll. At this point, what would you recommend? Immediate surgical excision with wide margins, core needle biopsy, get an MRI, refer her to an adult breast surgeon, or observe with serial ultrasound. Looks like most of us are biopsying in some way, either to excise or to do a core needle. Some people are referring to an adult breast surgeon. Some people are doing ultrasound. Okay, let's go back to the slides. All right, so to put us all on the same page, I'm going to summarize the BI-RADS classification for you all, since I suspect it's probably been a little while since anybody thought about this. So BI-RADS stands for Breast Imaging Reporting and Data System. It was created by the American College of Radiology for mammographic interpretation, especially to provide more consistent assessment and management of non-palpable breast lesions. It characterizes lesions based on the risk of malignancy. And importantly for this discussion, BI-RADS is validated in adults. In 2003, BI-RADS was expanded to ultrasound. BI-RADS BI-RADS categories are linked to malignancy predictions and management recommendations in adults. I'd like to highlight BI-RADS 4 classification here. BI-RADS 4 is broken down into BI-RADS 4A, 4B, and 4C based on the associated risk of malignancy in adults. BI-RADS 4A lesions have a risk of malignancy between 2 and 10%, 4B lesions between 10 and 50%, and 4C lesions are thought to be highly suspicious for malignancy between 50 and 95%. Further, it has been documented in the adult literature that although lesions might have benign characteristics on ultrasound, making them more appropriate for BI-RADS 3 classification, radiologists might prefer to classify palpable lesions as BI-RADS 4A. Therefore, palpable breast masses in adolescents often get a recommendation for biopsy, even though they are likely benign. Here we summarize our findings from the systematic review regarding question 3. The applicability of BI-RADS classification in adolescent females. There were 3 retrospective reviews, all had level of evidence 4. There were 190 patients who were likely all female, although this was not always specified. The age range was between 13 and 18 years. We were not able to calculate mean or medians, as 2 of the 3 papers that had these patients in them, we had to pull out subset analyses, so we couldn't figure out exactly their ages. 158 patients had a BI-RADS 1 or 2 lesion. There were no malignancies in this group. 18 patients had a BI-RADS 3 lesion with no malignancies. 14 patients had BI-RADS 4 lesions with 1 malignancy, which was characterized as a spindle cell neoplasm. Only 1 of the 2 papers that had any BI-RADS 4 lesions broke them into 4A, 4B, or 4C classifications, so we're not really able to say much about that. And unfortunately, the 1 patient that did have a malignancy, there was no context provided given the size, rate of growth, any prior history of radiation, or imaging findings. No patients had a BI-RADS 5 lesion. So for our systematic review with regard to BI-RADS classification in adolescent females, we conclude the following. 1 should interpret BI-RADS classification with caution in adolescent females, and the overall rate of breast malignancy in this age range is very low. And I'm going to turn it over to Melissa Danko.
So in our literature review, we did find 3 other relevant papers that were unfortunately excluded from our data because of our age ranges that were set a priori. So I just want to discuss these because they're pretty great papers. The first one came out of San Diego. It was a retrospective study looking at all surgically excised breast masses at a pediatric hospital over a 4-year period. The patients were females, all aged 11 to 19 years of age. They described 119 breast masses in 105 patients. All of these masses were palpable on exam, and of note, about a quarter of these kids had a family history of breast cancer. All of these patients underwent an ultrasound, and every single one of these masses was described as having benign imaging features, which included hypoechoic or isoechoic echo texture, circumscribed margins, or parallel orientation. They, on average, had a size of 3.5 centimeters, and then, of note, the BI-RADS classification was available for 51 of these masses. So this is a table showing those 51 masses with the BI-RADS classification, and as you can see, all of the pathologies were benign. I specifically want to highlight that the 25 patients that had BI-RADS category 4 all had benign pathology. And then when we expand this to the surgical pathology of all of the masses that were analyzed in this study, you can also see that there were no malignancies at all. So the conclusions drawn by this group were that in pediatric and adolescent population, BI-RADS classification overstated the risk of malignancy. They recommended that surveillance is appropriate if these lesions are benign in appearance, and they recommended that further validation is needed for the use of BI-RADS in pediatric patients. So a couple years later, groups in Arizona performed a multi-center retrospective study looking at patients ages 10 to 20 years of age, all females, and they had 283 patients that were included with breast pathology results. 227 of these had preoperative ultrasounds, and of these ultrasounds, 84% were assigned a BI-RADS category. BI-RADS 4 was the most frequent category, being assigned in 55% of these patients. Again, all of these masses were palpable. 89% of these teenagers presented because of a palpable mass, and the remainder presented secondary to pain. And then another thing that was really important to note is that the pathology, again, was benign in all of these patients. And for patients who had a core needle biopsy first, in this study, the final excisional path was concordant in all of these cases. So this is their graph, breaking down all the categories of BI-RADS, seeing all of our benign pathologies. And then importantly, that second column listed the malignancies predicted by the BI-RADS, and you see it completely overestimates the potential for malignancy in these kids where it was 0. So they concluded that the use of BI-RADS overestimates the likelihood of malignancy. You can see our theme. And that BI-RADS could unfortunately lead to more biopsies in these children, which are unnecessary and misleading, as well as can lead to disfigurement of the adolescent breast. So they cautioned to consider BI-RADS associated recommendations for biopsy with caution. The final paper is more recent, out of the Midwest Consortium. This is a retrospective cohort study. It looked at female patients aged 10 to 21 years of age who underwent surgery for a breast mass. This included 453 patients with a median age of 16 years old, and 98% of these patients had an ultrasound. You can see the pathologies listed, including fibroadenomas, juvenile fibroadenomas, and phylloides. So of these phylloides tumors that they looked at, 13 of them were benign, and only 1 was borderline. In this study, 2 patients did have malignancy, but these were both secondary malignancies or recurrence of a previous malignancies in patients with osteosarcoma and T-cell lymphoblastic leukemia. So then when they did a subset analysis looking at BI-RADS, only 28% of children had a BI-RADS classification on their ultrasound. And in this table, you can see that of the BI-RADS category 4, there were 67 patients, and none of them had a malignant tumor or a phylloides tumor. So they recommend that 4 patients with a phylloides tumor did have BI-RADS classification, and no patients with a phylloides tumor had a BI-RADS 4 category assigned. So they conclude that BI-RADS has a 0% sensitivity for phylloides tumor, even though this is an extremely small sample size. So their conclusions align with the conclusions of the other 2 papers that we just reviewed, that imaging size and BI-RADS scoring do not reliably differentiate fibroadenomas and phylloides tumors in children, and that surveillance and reassessment of growth over time is generally safe before offering surgery. So overall, for our question, as I've emphasized, the use of BI-RADS overestimates the likelihood of malignancy in adolescent females where the baseline risk of malignancy is very low. Instead of recommending biopsy, a more pediatric appropriate recommendation would be to refer to us, pediatric surgeons, or an adult breast surgeon with pediatric expertise. And then invasive breast biopsy in pediatric patients should not be used in the absence of rapid growth, high-risk family history, or prior radiation exposure. And I'm going to turn it back over to Barry to talk about our overall conclusions.
Thank you so much. I think those cases were great and really exemplified what we're trying to convey today, and thank you all for your participation. The overall conclusions is that the vast majority of breast tumors in adolescents are benign. The incidence of breast cancer in women younger than 20 years is 1 in 1 million. And from a recent SEER database, the incidence is less than 0.2 per 100,000 women 19 years and younger. Secondary malignancy from prior radiation are more common than primary breast cancers. So the current literature does not provide strong evidence of criteria for biopsy or surveillance timeline. And current expert consensus suggests that 6 to 12 month surveillance for benign appearing masses less than 3 centimeters may be appropriate. More ongoing work is needed for 3 to 5 centimeter lesions. And of course, patient and family preferences are important in this discussion and shouldn't be excluded from the conversations that we're all having with these families. So ultrasound is informative in the initial evaluation of breast masses to detect high-risk features and objectively document mass size for future comparison. But further validation is needed for the use of BI-RADS in pediatric patients. BI-RADS classification overstates the risk of malignancy. Even BI-RADS 4 tumors are overwhelmingly benign. And what's important to understand is that BI-RADS does not take into consideration size. But as you've seen from some of the recommendations from our cancer committee and other manuscripts out there, we use size quite a bit. And so that discrepancy is also interesting to think about because that's not anywhere in the adult recommendations for BI-RADS. So surveillance is appropriate if everything is benign in appearance, it is a small lesion, it is not growing, and algorithms exist for clinical follow-up or imaging follow-up for likely benign palpable breast masses in pediatric patients. So I'd like to thank the Cancer and Outcomes Committee and those listed on this slide who really helped participate in this work today. And we'd like to open it up for questions regarding the cases that we've had or any things that come up for you while you're all taking care of these patients in the office.
Owens. I guess the question I have is if we're really saying that BI-RADS isn't applicable, and we're also recognizing that these can be really emotionally charged conversations with families, should we be asking our radiologists not to include it in reports in this age group?
Yeah, I think that's the struggle that some of us have. You know, I think some of us who are at pediatric centers with pediatric radiologists reading these and interpreting these ultrasound reports don't have to deal with BI-RADS. At the institution I'm at now, there's never a BI-RADS given when it's done at our institution. However, a lot of these ultrasounds are performed at outside referring facilities or potentially even an adult breast center that's associated with your institution. And at my former institution, we had numerous discussions with our adult radiologists and our adult breast surgeons and could not get them to budge. So I do think it's really important to have those collaborative discussions and potentially for us to continue to put out more literature to prove that. And maybe we can get some sort of shift for these patients that are, 15 to 22 years of age or even up to 25, because that's really when the incidence of breast cancer starts to increase. But it is a struggle, and like you said, it's really hard because the families see those reports now, and they come in, very nervous and very upset, and then are shocked when you're not recommending some sort of intervention.
So one middle ground that we've found in Boise is that when we were able to meet with the adult radiologists, they would not stop reporting BI-RADS altogether, but we had them change their dot phrase of how they interpret that. So instead of saying this is concerning for malignancy, must get a biopsy, now it says we recommend that you meet with a pediatric surgeon to discuss observation versus intervention. And so when they've come to see us, they're a little less scared. But I've been encouraged as we've done this project to hear that other hospitals are able to cut out BI-RADS altogether. For us, that wasn't possible yet, hopefully eventually, but to be able to change that automatic phrase that pops in as soon as they click BI-RADS 4 has been really helpful.
It's also complicated to know at what age to start and stop doing that. As we know, the risk of cancer is going up in some young adults, so is that 18, is that 19? Where is that line as to where you can stop reading BI-RADS or start, which I think we might all have our ideas, but it's not entirely clear. And also, I think at some of, there might be larger children's hospitals that have pediatric radiologists, but where I am, people come with ultrasounds from all throughout the community and reports that it's very hard to have that conversation with the vast majority of radiologists who are reading this, who are, I think, relatively mandated to provide a BI-RADS recommendation whenever there's any breast ultrasound or mammography. So we're hoping to keep that conversation going, and I think the more data that our two committees are trying to put out there to try to at least change the way we think about this is going to be critical. So I have a question back to the group. Some of the questions that we asked about the utilization of core biopsy, and there's very limited data regarding the utilization of core biopsy in our age group. I'm wondering if there's anybody in the audience who wrote that they would recommend core biopsy in any of these circumstances, would be willing to discuss their experience with core biopsy. Or anyone on the panel? Great, thank you.
Candace Haddock, Valley Children's in California. I wish that the American College of Radiology would just put a little asterisk saying that this BI-RADS is not appropriate for interpretation for pediatric breast masses, because I get this all the time. We have a huge catchment area, and it really, I feel so offended when my patients come in with core needle biopsies, because it's stressful. We all know this. It's stressful. That's painful. It's completely unnecessary. Mm-hmm. And so I don't have that many patients that go on to get core biopsy before they see me, but it's upsetting to me and to the families when that happens. And as you pointed out, sometimes it's for something that can simply be observed. It doesn't meet our criteria otherwise for resection. And so I don't know. I think we need to have conversations with the American College of Radiology to have a broad statement that goes out around this. And again, I realize the age is an issue, but clearly for the younger patients, it's totally inappropriate. And so I wouldn't get a core biopsy unless it's something really concerning.
Great, thank you. I think core biopsy is tricky because, number one, after core biopsy, even if it comes back as fibroadenoma or fibroepithelial lesion, they're still going to be recommending surveillance. So it's not that it would take away any anxiety or resource utilization for surveillance anyway. They still have this mass that may grow and need to come out anyway. And of course, it adds anxiety, pain, cost, et cetera. So we also are thinking a lot about the utilization of core biopsy in adolescents. Great. Dr. Baird.
Hey there, Rob Baird from Vancouver. So first of all, just want to thank the group for such a great presentation. I think it's a call to action, frankly. I think it sounds like someone needs to do, and there's a lot of smart people in this room, but it's time to start thinking about a pediatric BI-RADS or something that's much more appropriate. And I was also struck by the lack of patient-reported outcomes. As it's been said many times, this is a highly charged, highly emotional circumstance. It's time to hear the patient's voice officially in the literature so that we can be better clinicians towards these patients. Thanks again.
Yeah, thank you for that. We are actively working on that exact comment. So we're to be continued. Please look out because that's coming. Anything else? Any other thoughts or questions? Well, great. Thank you so much for this great discussion. Oh, wait. No, that's perfect. We have time. Please, Sam.
I wonder if a position statement from our organization that we shouldn't be getting any sort of mammography for teenagers might be appropriate, because it's never helpful. I don't know. Is that something we could do? That ultrasound is the modality we're looking at, and we shouldn't be getting that. That would kind of supercharge this, and might change radiology practices.
I think it's a great start. Does anyone, I guess show of hands, does anyone find that their adolescent patients are coming with mammography or recommendations for mammography?
Not recommendations, they're coming with imaging sometimes.
I think a position statement's a great idea, and that could be included as part of it, that ultrasound is preferred, not mammography, that we don't recommend using the same BI-RADS interpretation, and maybe if we're able to join with radiology, we could disperse more widely in a national scene.
Yeah, there must be some places that are doing that. We did not find any patients in our systematic review, given that we actually had to exclude a lot of those better papers, unfortunately. I know the Midwest Pediatric Surgery Consortium paper, there were a couple of patients with both MRI and mammography. So this is happening to a low degree, but it's happening.
There is, when I've been discussing this with some people, I don't know, for those of you who may know more about this than me, there was when you get a DEXA scan, there was a time where there wasn't a separate pediatric DEXA result. And so many children were being diagnosed with osteoporosis and osteopenia before they made a pediatric specific DEXA scan result. And it reminded us of something that we can do, because they're getting these recommendations and scares of malignancy when we have just shown, and we're even in our own practice anecdotally, I think we all know that we shouldn't really be interpreting it in the way that they are. So thank you for this discussion, and we're going to continue to push forward and try to change things. Great.